I would like to invite the chairs of the different sessions we've had, Dr. Molyneux, Dr. Ousmane, Dr. Tamman, Jean-Francois, Dr. Jean-Francois, Dr. Harriet, I don't know the last names, I'm very sorry, to come up and join me up here in the panel, because what we're going to do is to just give you a 2-minute feedback of what we retained from those sessions and what we think might be the take-home messages, maybe, and so that we don't completely forget what happened yesterday, what happened today, and it might serve as some kind of a summary of what has happened in the last 2 days. So we'll start with Elizabeth.
Thank you. And my co-chair is sitting over there, so I hope she'll add. Okay.
Yeah,
okay. Well, you can correct me if I'm.
I think if you can add something in the end, then you will be more than welcome.
Okay, we had a very interesting and I think instructive session on shock. And it probably left us with as many questions as answers. To start with, we have different definitions of shock, and we have perhaps on one side the WHO, one where you need quite a lot of signs together, to one that is much softer, and I suppose the softest one that was shown to us was feast. So, you know, there's a lot of room for discussion as to where exactly we go with that. Perhaps even the word shock, because it means different things to different people, and we could talk about severely impaired circulation and impaired circulation. And then we talked about boluses of fluid, and were they really boluses, or was it extra fluid we were talking about? Because I think, again, bolus implies a certain action, which wasn't always what was actually being done. Then I think we found that perhaps some of us thought we knew how to manage shock. We've had our thoughts turned on their head by particularly the feast study, and that it's much more complex and difficult than we thought, and needs to be broken down. It's not as simplified as we've thought in the past. And so we had some very interesting presentations. I think we had Andrew Argent telling us about anemia, and that there is value in restrictive, also value in liberal hemoglobin levels, and we need to think carefully about where we are with that. We were shown the results from the feast study, which clearly showed that in a certain group of children, and that excluded the hypovolemics, excluded the malnutrition, excluded the trauma. So we're talking really about a group of, some of them anemic, but septic children, that those children did less well if they were given extra fluids. And then we had Mike Levine trying to break down the groups to see whether there were certain groups within that feast groups that did better or worse. And it did seem to be that the anemic children didn't do well if you gave them fluid. There was a large group of children who had a very low mortality and possibly didn't do better and didn't do worse with fluid. And then we had a group of children who had bad lungs, bad brains, and they did worse with fluids. So trying to sort of come to some sort of conclusion with all this is quite difficult. We had Joe Carcillo telling us what can be done as very best practice in the very best environment. And I think what you need to do is think what is best for the child who I'm looking after in my environment, with my experience, and with the team that I've got. And I think that's really where MSF needs to put its thoughts. We can't individualize treatment completely, and we do need some sort of guidelines. And from our discussions, I think we did see clearly that the anemic group are one group. We have got another group who are dehydrated. We've got another group who are malnourished. They need to be treated differently. And then we need to be extremely cautious with the children who came into what would be termed the feast sort of group. So I think that's where we left it. I don't think we came to any particular conclusion, but I hope everybody went away and dreamt about shock that night.
Yeah, we were. No, thanks a lot, Elizabeth. I think this is a question that, thanks a lot, just move a bit so Jean-Francois is not hidden by the TV screen. Yeah. Because it was a question that has been, well, bothering us for the last few years, I think, since the feast trial was published, and there were heated discussions inside MSF, outside MSF. I'm not sure that we got the answers we wanted, but after the official meeting here, where there were a lot of sideline discussions outside this room, and I do think that we will have some kind of constructive way forward for our next recommendations for the field workers, and I think this has been extremely helpful. So thanks a lot. I will continue with, I think, in the order of chronology with you, Dr. Ousmane.
Thank you very much, Chair. It's my pleasure to show you what we learned about this session on sickle cell disease. In this session, we have 4 presentations. The first presentation was a testimony of David Issam on his experience on the disease and its great philosophy to have a more positive perception of his illness. Patients with sickle cell disease need support and empathy. With this appropriation of his own destiny, he becomes an expert on the disease or a new patient. The other presentations focused primarily on the diagnosis and management with a focus on resource-limited areas. What can be done for a better understanding of the disease? What can be done for greater acceptance by families, including patients? What can be done for the diagnosis, the management, including prevention and treatment of acute and chronic complications responsible for morbidity and mortality? These presentations have all reported frequent complications such as respiratory infections and sepsis, anemia due to splenic sequestration and malaria, vaso-occlusive crisis, and ischemic stroke. Many feasible and affordable strategies have been proposed. Regarding to prevention, early detection by newborn screening at the point of care by a simple and rapid method like cycle scan, and the organization of early monitoring. Penicillinotherapy to prevent pneumococcal infections, and pneumococcal vaccination with specific 13 in the API. Malaria prevention by seasonal prophylaxis and mosquito and bed nets. Transcranial Doppler for the screening of populations at risk of stroke. Screening of the sequestration by the spleen examination. And we discussed also the use of hydroxyurea relying on precise information. For the treatment of complications, blood transfusion with secure products to avoid iatrogenic complications, exchange transfusion, availability of antipyretic and analgesic, including morphine, antibiotics, and oxygen. Regarding to the overall management, advocacy for access to vaccines, analgesics, and hydroxyureas, education of family and communication for better understanding of the disease within communities, and ownership of the management and fight stigma. To train staff of health facilities from the community level to the reference structure, integrate the management of sickle cell disease in primary health care. Thank you very much.
Thank you. That was quite impressive. Very I can't wait for this rapid test to be available. And I had a short discussion after the session, and I heard that it might be available, hopefully, within less than 2 years' time. So in MSF, we have to keep our eyes peeled, our ears open, and get this test on the field as quickly as possible, because I think that we have a lot of patients that just go unnoticed. And there's a lot of things we can do for these patients, and that even within MSF, they have been a big neglected group. So thanks a lot for this fantastic wrap-up. So, oh la la, now, who was next? I think, Tamman, you're next.
Yeah.
So
thank you.
I give you the word.
I was fortunate to chair the session that had two different topics. One was presented by Dr. Ramzi Nasser, who told us about his experience with addressing children with developmental difficulties. And in what is interesting here is, first, the proportion of children that we might face, especially he's told us about Jordan, and this is a context that we deal with, the protracted displacement, and many more people who are in need of longer care. The possibility of addressing children with developmental difficulties is evident, and the range of those difficulties is wide. We do what that brings to my mind is what we do in psychological counseling, which is a platform whereby what he described could be applied. The other two sessions by Dr. Christian Fabiansen and Emily Macher, Dr. Emily Macher, were about nutrition. Christian told us about the study they did in Burkina Faso, which was mostly looking at children who are at the same time short and who had low MUAC, middle upper arm circumference, and their comparison of the different available therapeutic feeding options. I wouldn't dare repeat the possible options, but I remember the isolate is better than the concentrate, so that's something to keep in mind. And Emily told us about engaging the mothers and the community health workers in malnutrition circumstances. Now, just to put it together, because Dr. Sahar told me a story on the coffee break, which I think is quite relevant. Here in Karolinska, they have more and more TB patients. And one of them was an XDR TB adult patient, for which they had to remove a lung. And to do that, they struggled to find a surgeon, but more importantly, they've adapted a whole operating theater to have negative pressure so they can actually operate on a highly contagious patient. I don't even want to know how much that costs. This is a privilege they have here. And in my mind, what that brings is that this is exactly the privilege we do not have, to highly optimize. We do invest a lot in facilities, and we have in the field facilities that many do not imagine to be applicable, but they are. And today, we still are dealing with populations in extremely difficult contexts. The reason I say that is because the operational challenges that people face in the field are some of resources, what we can and cannot implement, and some of capacities. The resources part are improving, and we've heard yesterday in the talks about what Christina told us about what she saw the first time she went to the field and what she sees now. So that comes on. The capacity and the conviction one is one to deal with. We do not have the privilege of specialization. We have to treat patients with generalists. We do not have the ability to choose diseases as one would do in Karolinska. I choose to be a dermatologist and I'll never have to see a child with pneumonia ever again or so. That isn't the case there. We have to be able to create a continuum from specialists who sit here and find solutions to journalists who can apply them in almost any given situation. And this is the difficulty. This is what shouldn't be allowed to be a bottleneck. So to repeat what, to paraphrase Marie-Claude, that she says repeatedly, because someone said that we didn't think about babies before and we do now, fortunately. I don't think pediatrics in MSF is not the business of pediatricians, but an obligation of all of us, and that's what we are hoping to achieve here. Thank you.
Thank you very much. That was fantastic. And I can't stress enough what Emily Machera kind of alluded to, that we do not communicate enough with our patients, and we don't communicate enough with the parents of our patients. And I hope that hopefully in a future meeting like that, this could be also a topic that we can address in a self-critical way. So next in line was, I think, yes, that was the end of the day 1. And then we had the day 2, which was dedicated to newborn care. I don't choose the word neonatology because I don't know it. I choose the word newborn care because that is what we want to deliver in the field. It's not about high-level neonatology. It's about context-adapted care to the newborn child, starting in the delivery room. So, Jean-Francois.
Thank you. To wrap up this session, I think the way to introduce it is the really kind of things that MSF does. It's put ourselves in situations that are complex or complicated. We know the bulk of infant mortality is in that period, you know? And now we want to put more effort into it. So I was fortunate to chair this session this morning. I think it had good logic into it, and I take it backward then from the presentation we had. I would start with the one by Anna. It talked about the what, okay? They said that in DRC, they managed to show that with using simple measures, going back to some of the basics, they were able to decrease, to show a decrease that was feasible and possible in neonatal mortality in the places where they were working. And then after that also, we had 2 sessions that talk about the how, building further on that. We had Ryan that talked about making breathing a bit more simple, bringing technology into the matter, but adapted technology, looking for things that we could or we should think about to adapt some technologies in the context where MSF work. And then we had the issue that we may think is complex, but we had a good presentation by Laura about now it's SSC, no, not kangaroo. Skin, or is it contact?
Skin to skin.
Skin to skin contact. Okay. So, and showing also that MSF, we do want to buy in and try our best in the context where we work, using the evidence that is around there. And these were things that we can do with the resources we have in the places where we work. And then, and I think one of the most important things when we ask ourselves questions before going into some of the matters, and that in MSF we ask ourselves a lot because we do have limited resources and we are working in complex places, is the why. And in the first session, our colleague Wilma told us that yes, they did some studies. Of course, you could show that you reduced the mortality. You could discharge more children, newborn children that went alive in the community. And the why is that why should we put more resources into that? Why should we try that much with these limited resources? And she said that even 2 years after, when they go to the communities, they found that a quite good proportion of those kids were still around there to live. So oftentimes, we don't have the ability to make this triage, but we do have limited resources in MSF. So where we allocate these resources are very important. But yes, we were very fortunate from this session also to say that it is not that always with complicated things. There are things that are around there that people are trying in the field and that can make this difference. And the why is because we do have an impact on this child. They are around there and they are living. So that would be part of what I got into that, and the other sessions, they went into more the technical parts.
Thanks a lot, Jean-Francois. And I just wanted to add to this that, in fact, one of the beauties of having this meeting here was to show that, yes, we had this one study showing the follow-up in Burundi, the 2-year follow-up, but in fact there is other, I know that there's been a lot about, what one section does, the other section doesn't know, like the left hand doesn't know what the right hand does in MSF sometimes. So this was also an opportunity to link those initiatives together, because there is a number of follow-up studies that are happening in newborn care in MSF, and it will be interesting to look at the different results in different areas with different approaches, and see how we can improve what we're doing, not just for survival, but for a better survival of those newborns, because that's what it's all about. Following on from that, it was the session that I had the pleasure to chair. It was Mats and Niels. I can't see Niels anymore anywhere, but where is he?
In the middle of
yeah. I'm so blinded by the light, so... Good. I'm not going to spend a long time trying to reproduce what you explained to us on the pathophysiology of but what I'll tell you more, what I retained from your sessions as the go-home message for us. If I start with Mats, and oxygen and ventilatory support, non-invasive ventilatory support, is something that is, wherever it is possible, it is something that is extremely beneficial, and the evidence is there for showing that it does rapidly reduce mortality in newborns, in premature newborns. And that there is a lot of devices out there in the market, and it does not really matter which device we use, but if we decide to use one specific device, we have to know how to use this device, and that in the end, maybe if today we only use it as a high level or medium level of care, hopefully tomorrow it will be possible to use it at lower levels of care, and that's the challenge and the road that we might want to explore together. And the other thing that I retained from Mats' presentation was that we cannot do this work without nurses, that the nurses are the most crucial in implementing good care in newborns anyways. We knew that, and we always should remember that, but for sure CPAP is not something that the doctors implement, it's something that the nurses know much more about than we do usually. And then we had the skin-to-skin, so the KMC becomes skin-to-skin session, which was very passionate, and I think you had a very receptive audience here on telling us no baby is too small for skin-to-skin. Every baby benefits from skin-to-skin, and that it's not just a feel-good factor for mother, child, or whoever, but that there is real evidence out there, neurophysiological evidence, that it really does improve the outcomes for the children, and that at the end it has to do with the children being less stressed, and because the child being less stressed, the child feeds better and the child has better outcomes, breathes better and has better outcomes, and that even children that require support can also benefit from skin-to-skin. What again, once again, important message was we need to train people to how to do skin-to-skin, so we need nurses, and not only nurses, we can use nurse aides or whatever is available in our settings to put that in place. And we need space. And most importantly, as little as possible, separate the child from the mother or from whoever is there to give care to the child. And this space is a big challenge, in fact, in most of our projects. So I would have liked to have this session for a little bit longer to explore more of the challenges and how to overcome them. So very inspiring, and I hope that we're going to go home with those messages in our mind and try, when we go into our next missions, how to convince the people in the field how to implement them, but also convince people at headquarter level, because it's very often it's not the people in the field who needs convincing. It's very often people at headquarter level who need convincing that there needs to be more resources in order to implement specific measures. So this is a point of advocacy from my side at this moment. Harriet, you had the pleasure to chair the last session. And I'll give you the floor.
I think this session is still all fresh in our mind, and I would like to start with wrapping up the presentation of Professor Bouta, who started with saying that if you consider neonatal infections, you have to see the mother and the child as a pair, also in the prevention of neonatal infections. And luckily, that is almost our first sentence in our neonatal policy in MSF. So I think we make a good start there. And he mentioned several evidence-based methods for the prevention of neonatal infections. And if it would be possible to roll these out globally, we could prevent a huge amount of neonatal infections. And the methods he mentioned were the clean birth kit, the early and exclusive breastfeeding, the skin-to-skin care, the cord care with chlorhexidine, and the skin therapy. And as a last method, he mentioned how we can engage the mothers to care for their children in an intensive care, which might also have a beneficial effect on the prevention of neonatal infections. For the treatment, he mentioned the option of simplified antibiotic treatment in the community. And I think that for MSF is a very interesting option to consider. In several of our projects, we are starting to work with integrated management of, integrated community case management, where at this moment we do not treat neonatal infections yet, but that might be something we should discuss and consider in the future. Then we had a very nice presentation of Uli Muller on what can happen in a pretty advanced neonatal unit when there is an outbreak of a resistant infection with, in this case, the ESBL positive Klebsiella. And it shows that mortality can increase a lot and that it is very difficult to tackle. And one of the things that Uli showed is that there is a direct relation between the bed occupancy rate and the prevalence of infection. So that is something that should trigger us. How do we think about having 2 children in one bed, and how can we try to improve this? It also shows that with infection prevention, you can decrease a lot your infection transmission, but that it is tough and that it needs continuous support. And I think that brings me to what I think is really important there. Infection prevention, I think, is a very basic measure, and we should make sure that all our basic principles are there first before we start stepping up into an advanced level of care to be able to prevent these problems to happen in the future.
Thank you very much. And in fact, I think that Uli's presentation and Safik's presentation could somehow be complementary in the sense that if we had shorter hospitalization times for children, for newborns, we would be able to have less the challenge of having 2 or 3 or 4 children per bed, and therefore we could reduce nosocomial infections. That you know, somehow it all, thankfully, it's not different subjects that don't have anything to do with each other. One thing that we have not touched upon, and that did, and you just in the end touched upon it with regards to levels of care. We did talk quite a lot in the last couple of days about levels of care. We did talk about the definition of at what level of care we can do what. And when I mean levels of care, we talked about organization of care, we talked about patient flow, and that it's not just a protocol that will fix the problem, but that it is a whole number of measures, and very importantly, one of that is the organization of care and patient flow. So I just wanted to add that because it should not be forgotten, and it has been mentioned several times over the last few days. So I really want to thank everyone in the audience who has spoken, who has listened, who has contributed, for inviting all of us to be here and to exchange. And I hope this is just a beginning of ongoing exchanges, be it formally, informally, and whatever grows out of this. So thanks a lot to the organizers.
We still have time for some questions.
Okay, so we start with you because I had neglected you before.
Hi, given the title of the session is Conclusion and Recommendation, so I have a conclusion and a recommendation.
Cool.
The conclusion is, well, the 2 words are privilege and protection. So the privilege is everybody here, that we all, I know this is online, but we give a shit about children and we want them to get better and we want to do it in the right way, and we're really struggling to get this right. So it's a privilege. Oh, I got emotional. But the recommendation is protection. Now, as MSF, we are very good at talking about protection of civilians, and increasingly and sadly, protection of healthcare workers. We as paediatricians and paediatric community have a duty to keep talking about child protection, and we don't talk about it enough, and if you don't look for it, you don't see it, and I think we have a bit of a journey to go in the global health world relating to child protection. So my recommendation is in the next scientific day for paediatrics that we try and look at that too.
Could you explain what protection means for you? Because this is a co-opted word in the humanitarian world, and there is a very, you know, delineated program for what does it mean to you, because that might be very different from what an audience would take it to be.
So it depends on the audience that you're speaking to. So the audience of pediatricians in the West view child protection in the holistic care of the child, and we have definitions of things about neglect, abuse, sexual violations, etc. So it's our duty, not as a pediatric community, but as every member of society, whether you're a teacher or a parent or anyone, to look after children, because that is our duty as a community. We also have that in MSF. We talk about we shouldn't be bombed. Our hospitals need to be protected, and there are 1 million statutes, and they're talking in the UN General Assembly again about protecting healthcare workers from to deliver this precious care that we have. So I'm not going to give an essay on protection, but I think we all. I think it's the former protection of children in our societies as we come across them, that we as this pediatric community can put on the table, because it's not on the table and it is a problem that is coming up as questions.
Mm-hmm. Okay, thank you.
And,
we're very, very short.
To extend it just a notch further, I agree, it's not the political, that it has a place, but it is probably not what you're talking about. But it also extends in our situation where there isn't a police and a judiciary to protect children from abuse. We need to decide as an organization whether that is our business or not. When you can't just call the police or tell a judge, or very recently we've seen a situation where mothers were keeping one child hungry so they can still take Blantyre to the other children. Mm-hmm. That is where I fail to perceive what should we do, mm-hmm. and how should we do it.
So a very vast topic, and we will have to choose which aspects of it we might want to address. Marie-Claude.
Yes, according to your suggestion, I can conclude that you think the day was successful and you want the other one. So I know Laurent will talk about, so I will not do it, but be sure that a lot of very important topics like HIV, pediatric, etc., were not discussed today. So probably we will open a seat or discussion to get all your suggestions for the next. So because it's impossible in 2 days to, yes. So it's just that I wanted to say, but Laurent will do it later.
Thank you. Any other questions, comments, recommendations, burning issues, exhaustion? Wonderful. Yes.
Merci. Mayam Silla du Mali. C'est d'abord de remercier MSF de m'avoir donné l'occasion de participer à ces premières journées que j'ai beaucoup appréciées, que j'ai trouvées enrichissantes. Deux, c'est une demande sur le terrain. Les sociétés de pédiatrie organisent des rencontres. Est-ce que les équipes MSF pourraient par moment se joindre à nos sociétés pour partager leur expérience du terrain que je trouve vraiment très, très enrichissant. Voilà.
Okay, I'll just quickly translate, and you can correct me if I'm wrong. But first of all, you wanted to thank MSF for having given you the opportunity to participate into this meeting. And then you would like to extend an invitation to MSF to join the Society of Paediatrics meetings that are happening in the field in Mali, I take it. Or wherever there is a Society of Paediatrics in the country that we work. Fantastic. Yeah, well, for that, we just need to set up the networks because, unfortunately, sometimes MSF works a little bit in a siloed way. And I think this is a very good opportunity to open up this silo.
Peut-être one comment for that in French.
Did you understand me in French? Yes, you have it. You have a translation.
Non, en fait, je suis d'accord avec Mariam. Et c'est une bonne chose. Et je pense qu'avec Laurent, on a fait beaucoup de pas par rapport à ça. Moi, je suis le secrétaire général de la Société sénégalaise de pédiatrie. Voilà. Et on a voulu associer cette année Médecins sans frontières à l'organisation de notre congrès, dont le thème était la prévention des maladies infectieuses. C'est vrai qu'ils n'ont pas fait de communication, mais ils avaient un stand. Et je pense qu'à Dakar, Laurent est allé très loin et il collabore beaucoup avec l'université.
Excellent.
Voilà, nous on fait des formations en partenariat avec Médecins sans frontières, donc pour la formation du personnel qui est dans la sous-région, sur tout ce qui est soins essentiels, kangourous, etc. Voilà.
Even
donc
kangaroos in Senegal.
Voilà,
so, so just to translate for those, or to just give you a summary of what has just been said for the people who don't speak French. The first steps have been already made in Senegal, especially together with Laurent. and MSF has been associated to the latest conference or Congress of Pediatrics this year, where the emphasis was on the prevention of infectious diseases. However, this time MSF was only able to have a stand, but hopefully next time MSF will be able to participate in a more participative way, in a way like contribute with presentations, etc. Voila. Any other comments? Yes, Jean-Francois.
Well, thank you. So I think if it's from my part, I'm working for one of the operational centers. I want to thank the people that organized that, MSF Sweden, for their associative that requested also that this issue should be looked at. And then we have the colleagues from the pediatric working groups that took it really forward, all the colleagues that supported and make this planning, and all the external people also that, that support that this took place. Just to make a mention that, okay, in MSF also we have several, or we will say very few, scientific days or pediatric days. So maybe even the name might change, because we will have a big dilemma if we start having pediatric days, midwife days, surgeon days, etc. But this was very pertinent for this time. Just to say that oftentimes MSF, we are under the spotlight really trying to do better. And we do need academia. We do need your associations also in the places where you work, because oftentimes we are confronted with situations of policies that are not comprehensive enough. The support that we need from other colleagues that are talking about the evidence, because we are working for very specific vulnerable populations where we do need also the collaboration of those networks. That we are not only seen as MSF advocating for the issues alone. So we want also that you take with you some also of our concerns, our bottleneck, our challenges, and in the context where we are working, we cannot always, or most of the time, we cannot do those big pieces of research, operational research. We have advocacy that is being done on the model that we have right now for research and development that is not really taking into account those most vulnerable most of the time. And we do think that academia and all these colleagues external, you have a role to play, because you talk also with these big guys or big people that are around there. So we want to take back also the ball in your feet, and we thank you also for your collaboration in that meeting.
Fantastic, thank you. Thanks, Jean-Francois. So I think if there is no one else who wants to say something, I want to thank again everyone, and first and foremost MSF Sweden, to have allowed us to be here.